Okay, so today, lower respiratory system drugs. So lower respiratory system, we talked about the upper respiratory system. What was included in that? Pharynx, larynx. Yes. So if we're talking lower respiratory system, what are we talking about today primarily?
Like the alveoli.
The alveoli at the very bottom. What's above that? Bronchioles and bronchi. Okay, specifically the bronchi. That's your little. We used to have some cool little A&P stuff in here where I could take it out and show y'all, but I think they cleared out all the extra stuff, you know, to help with infection control. But your bronchi, you have your main branches that are going out, and then your bronchioles are branching off of that. Okay, so we're talking about drugs that are treating those things today. So the disease processes that we're talking about yesterday, some of the upper respiratory disease processes were what? What did we talk about yesterday? What caused those upper airway issues primarily?
Like
Sinuses, what else? Allergies, those are the main things. The things we're talking about today are lung issues, more so than, you know, upper respiratory stuff. So we're talking, what are some lung issues that y'all know about? Lung diseases. Asthma. COPD, perfect. Those are the two biggies. So you have COPD. So these are going to be the drugs that treat them, that treat COPD. And within COPD, you know, that's chronic obstructive pulmonary disorder. And then your subcategories off of that are asthma, emphysema, you know, all of those little subcategories. So those are the things we're going to be talking about treating today. So I needed to show you all this. I keep talking about adrenergic drugs and cholinergic drugs. And we really, do y'all know anything about that yet? Or y'all just really keep hearing me say the words and you don't really know? Okay, so I need to show y'all, all right, you remember we have the autonomic nervous system? The ANS? And it has two branches. What are the two branches? Fight or flight, what's it called?
Sympathetic.
Yes. Sympathetic and parasympathetic. Okay, so those are our two branches of the autonomic nervous system. Parasympathetic. All right. So we have 4 drug classes that keep showing up. We keep hearing the word cholinergic and anticholinergic, or adrenergic and anti-adrenergic. Y'all heard me say those words before. Remember we talked about our beta blockers and we said they were adrenergic. Okay, so if something is sympathetic, another word for that is adrenergic. Okay, and it has to do with acetylcholine. Parasympathetic are cholinergic drugs. Now this is where it gets complicated. And we're going to learn about these drugs a little bit more, but today, a lot of the subclasses are adrenergic. You need to see this one. Better or not really? Okay. So you have sympathetic drugs, which are adrenergic, and then you have parasympathetic, which are cholinergic. So these drugs cause a sympathetic response, which means that they increase what? What's that fight or flight response? And adrenaline. So what happens when your adrenaline is increased?
Heart rate goes up.
Yes.
Blood pressure.
They increase heart rate. They increase blood pressure. Okay, primarily, along with other things. So, a while ago, we were talking about, not a while ago, last week, we had our adrenergic blockers, which were beta blockers, which meant that they decreased heart rate and blood pressure, right? Mm-hmm. So, surprisingly, in that fight or flight response, your body, so I pulled up a little thing I want to read to you guys just so that I don't make it complicated. Because today we're going to talk about those normal responses. Okay, look. This image is, I need to do it over here. I promise this has to do with your lecture today. It's just easier for me to show you ahead of time.
Grammarly does more than catch error.
I just want to show this picture. Y'all can't see it, huh? Not very well. Here we go. All right. So the parasympathetic responses outside of drugs, you have the parasympathetic responses and the sympathetic. So let's talk about the sympathetic first, because we already said some of that. Sympathetic dilates the pupils, increases the heartbeat, and it dilates the bronchial tubes. Okay. Active activity stimulates the production of adrenaline, causes vaginal contraction, and relaxes the bladder. Okay, those are the natural things that it does. The parasympathetic response, as far as everything goes, is pretty much the opposite, mostly the opposite. If you remember one, then the other is the opposite. So when we're given these drugs, today we're going to be talking about the airway. So sympathetic drugs are going to open up and dilate those airways. Okay, so when we start to talk about, when we say, if it's a parasympathetic blocker, then it's doing the same thing that a sympathetic drug would. Does that make sense to you guys? So I'll post one of these videos for you, but when I start saying sympathetic, parasympathetic, all of those words, that's what we're talking about. So cholinergic is going to be used interchangeably with this, with parasympathetic, and anticholinergic is going to kind of go with this, okay? Just to kind of keep all those words, that's where I'm pulling them from. That's what that stuff means. And we're going to go specifically later on into cholinergic drugs and anticholinergic drugs. But when we start talking today about both the drugs that affect the stomach and the drugs that affect the lungs, you see that some of these normal, if the parasympathetic response is to stimulate activity, then one of our mechanisms of action is going to be to block that response. That makes sense? Same way with our, we're going to use these as blockers or drugs that aren't blocking. So that's just kind of like an overview. When I start talking about it, we're going to go way more in depth with this, but if I just start talking, then you're not going to have any idea what I'm talking about, okay? You feel okay enough to move on? Okay. You okay, Kat?
Yeah, you said the sympathetic is fight or flight, right?
Yes.
Okay, and you said it relaxes the bladder?
Sympathetic? Yes.
Okay, because I don't know, I just remember when I learned about it, it was like fight or flight, like everything stops.
Everything constricts. I might have said that backwards. Everything constricts.
Okay, so the bladder
Except
constricts.
for the bronchioles. The bronchioles dilate because we need to get more air.
Right.
So, but everything else is constricting. Peripheral vessels, everything else is constricting. All right, so sympathomimetic, which means it mimics the sympathetic response. Bronchodilators are used to open the bronchi and allow more air to enter the lungs, which in turn completely or partially relieves respiratory distress. So that's the way it's working. It's acting like your body is having that fight or flight response. So it's opening those vessels. But so if we know it's acting like a fight or flight response and it's opening the vessels, what do we think might be happening to our heart rate when we take this drug? It's going to increase because our fight or flight mechanisms are enacted. So do you think we might be a little bit nervous, a little bit shaky, a little bit, all of those fight or flight type things are happening at the same time. So if you can memorize the chart, I'll find a little more simplified version, but if you can memorize what a parasympathetic response looks like and a sympathetic response, you're going to know what the side effects of these drugs are, and the people that we shouldn't give them to. So the cholinergic blocking drug, ipratropium bromide, is used for bronchospasms associated with COPD. So remember I told you if it's cholinergic blocking, and that would be the same thing as sympathomimetic or, that fight or flight response. So it's used for bronchospasms associated with COPD, chronic bronchitis, and emphysema in emergent situations. So the main thing that I'm going to have you guys remember about these drugs, we're going to have some drugs that are going to act immediately. They're going to be given emergently. And then we're going to have long-acting bronchodilators that are not for emergency events. So like, I'll use my husband and my daughter a lot for these examples. So my husband's been an asthmatic since he was like 4, but he's also a non-compliant, doesn't do what he's supposed to do. So he's been prescribed Advair, which is a long-acting bronchodilator, but it doesn't work immediately. And then he has his albuterol, that he carries with him all the time, that if he has asthma, it's going to work right away. So his doctor or whatever, his nurse practitioner is like, John, why are you getting these filled so frequently? Why do y'all think he's getting his fast-acting inhaler filled so frequently? What is he not doing? He's not doing the long-acting inhaler. He's not doing his preventative or his maintenance inhaler. So if we have a non-compliant patient, what are we asking them? Like, what if we're investigating why he hasn't taken this? Yeah, we would just ask him, why aren't you taking this? Why are you not taking this medication? What's the problem? And his issue is it's a routine. He forgets, and he just forgets, and he knows he has his other one if there's an emergency.
Quicker, so he gets the class quicker.
Right, he gets that immediate relief, and so the other one, so he doesn't necessarily feel that Advair working, but it doesn't work over one day. It works, it's long acting. So if he takes it in the morning, he won't use his asthma spray 3 times that day. But if he gets asthma, it is not effective at all. So being a good patient educator with those long acting versus those short acting bronchodilators, that's one of the main things that I want y'all to differentiate between. More so than is it adrenergic or sympathomimetic. I want y'all to kind of know how they work, and I want you to know what the side effects are, but I really want you to know, you be able to educate your patient. This is not going to work immediately, but this will. That way they don't get them mixed up and they understand the reason that they're taking them. All right, so we've already talked about this. The adverse reactions of the sympathomimetic bronchodilators are tachycardia, palpitations, cardiac arrhythmias, nervousness, anxiety, hypertension, and insomnia. So I haven't told y'all a whole lot about my daughter, but I have one daughter that is like cool as a cucumber. She's a preteen, so she has her little attitude, but she is so chill. And then I have my little Maddie. And my little Maddie is like, she does cartwheels everywhere, and she never shuts up, and she never sleeps, and she's like, woo, 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 like runs everywhere, and she's like me on steroids. I mean, she is off the charts. So she has asthma. So how do y'all think my little sweet pea acts when she takes her inhaler? Like a pure psychopath. So we're trying to say, baby, you have asthma. You need to sit down for a minute. You need to just sit down and take a break. So her already like, woo, it's like, woo, woo. Mommy, my hands are shaking. Mom. my girl. I'm gonna need you to sit right here just for a minute until your medication starts working, okay? So, those adverse effects are so apparent in her. John he's an adult, he's pretty much immune to it, and I say immune to it, he handles it. She's like, Mama, is my shirt moving? Because I feel my heart beating. I'm like, baby, it's not beating that fast. Like, you need to take a minute. So think about when you're educating your parents, like, it is hard to keep a kid who needs to be still, who's already not still, who's taking a medication that revs them up times a million, still, so that we can let the medication work and hang out. So when you think about symptomatic bronchodilators, think about Maddie. So they're contraindicated in patients, of course, with a hypersensitivity to the drug. We're not giving them to patients with cardiac arrhythmias, right? Because it's speeding them up already, especially if they have tachycardia. If they have cerebral arteriosclerosis, so think about that sclerosis that I told y'all, is stuff closing up. So even though we're dilating our bronchioles, what's happening to the rest of our vessels when we take these medications? The rest of our stuff is constricting. Overall, for the most part, everything else is constricting. So we're not going to give them to patients. So essentially, glaucoma, just for lack of better terms, when you think glaucoma and you think BPH, there's a whole lot more stuff to it. But think glaucoma is pressure behind the eyes, and BPH, that benign prostatic hypertrophy, that's pressure before the prostate. So patients who already have high pressure stuff going on in their body, we don't want to give them anything that's going to exacerbate that. That makes sense? Okay. You don't have to worry about that last part. Are you still with me, Kat? Okay. So they're going to be used cautiously in patients with hypertension. We know why. Cardiac dysfunction, hyperthyroidism. Somebody tell me why. Put those together. If our patient has hyperthyroidism, what is their system? What's going on with it?
Everything is already increased.
Everything is already increased. Exactly. Glaucoma, diabetes, prostatic hypertrophy. Remember, just like I said, for lack of better terms, think about that as pressure behind the prostate. And if they have a history of seizures and pregnancy and lactation, we're not giving these drugs to those folks, okay? All right. So as far as interaction goes, if we give these with other adrenergic drugs, adrenergic, sympathetic, same thing, we're going to have a 1+1 added effect. When we learn about MAOIs, they're not always the mainstay of treatment because they interact with a freaking lot, y'all. Like, y'all starting to see this word a lot. They interact with digoxin, and they interact with beta blockers, and they interact with this. So that's one of those things that the doctor is going to monitor closely. But when we get to MAOIs, if your patient is on one, then you just need to be aware that there's a lot of drug-drug interactions. Let's see. All right. So if we're making our little, you go to your book, and you're making your little tree thing, you'll find the book. And talk about the umbrella stuff. All right, we're on page 364. So if you were making your little umbrella, these are going to be lower respiratory bronchodilators. All right, and you see right here underneath bronchodilators, there's going to be subcategories of that. If you look on page 364, everything we just talked about are adrenergic or sympathomimetic drugs. Okay, that's what we just talked about first. We have long-acting beta antagonists. So essentially, same thing is going to happen, but it's not an immediate response, okay? Still going to dilate those vessels, but they're used in long-term treatment. Which one of these would be given in an emergent event? Yes. This is for emergent or immediate. I would say acute, more so than emergent. I should have said acute. For acute events. And this is for chronic. Is that making sense to you guys? Okay. Yes.
But they're both adrenergic?
Yes.
Okay.
They're both, so adrenergic is the same thing as sympathomimetic, but when we say sympathomimetic, they are mimicking the sympathetic response. So they're mimicking that fight or flight response. Okay. Then we have cholinergic blocking drugs, which remember I told you at the end of the day are basically going to do the same thing. If they're blocking the parasympathetic response, then the action is going to look very much like the sympathetic response. If they're blocking the parasympathetic, then at the end of the day, the action looks like the sympathetic response. Does that make sense? You have to like really kind of think. I have to say it really slowly, even though I know it because I always want to say it backwards. But if you were able to write those little things on your paper, the little chart that I showed you at the beginning, then you could talk it out and figure it out. But at the end of the day, they all do the same thing. And what is there? So this, the reason I like to draw these little things, can you see it, Kat? Perfect. Okay. The reason I like to draw this is because this is their mechanism of action. This is how they work. But what they do, what do we expect them to do? All of them. That's how they're working. What are we expecting to see in our patient?
Oh, to open the airways.
Open the airways, yes. So we talk about all these different drugs. The way that they do it, when I keep talking about the big umbrella and all the little stuff, the way that they work is different. But at the end of the day, they're all going to open up our airways. So when we're looking at our patient, how do we know if their airways are open? But I don't even have to do my PowerPoint. We'll go through it, but how do we know their airways are open? They're long sounds. What do they sound like?
Well, if they're closed, it's amazing.
Yes.
But they're clear.
Yes. So our assessment are their breath sounds. What else? Yes, their respiratory rate.
Oxygen saturation.
Yes. So y'all know all of this stuff already. You don't know the drug names, but you know what you're looking for. And you know, at the end of the day, when you're reevaluating their medications or you're reevaluating your patient, you know, yes, it worked. No, it didn't work. We need to go back to the drawing board. We need to further educate. Because really, outside of memorizing drug names, pharmacology is all about educating your patients. It's all about trying to, are you taking a picture of that?
Yeah.
Can you take a big picture so I can post it for some other people?
I just forgot my notebook. So.
No, that's okay.
I didn't see.
I'm fine with you taking a picture. I just want you to save it, like where it's a good one, so you can text it to me and I'll send it to the night class. All right, so then off of this, I'm gonna have to erase it, but we'll have another class. So this is the bronchodilators class. So if we're erasing all this, is this helpful or are you going to stick with my PowerPoint?
No, that's helpful.
No, I like-
This is
I like
good.
This is how I normally teach, but
Yeah. Are we not talking about the Xan thing?
we're about to move on to the next one. I think intranasal steroids, I don't know what's next. Hold on. Okay, yes, we will talk. The only thing I needed to thank you for pointing that out. Xanthine derivatives goes underneath here too. So we have 4 subclasses underneath bronchodilators. So what you need to know about xanthine derivatives. Remember we talked about drugs that have a very, very narrow therapeutic range? All right, xanthine derivatives have a very narrow therapeutic range. So at the end of the day, they open the airways. But if there's labs that go with them where they must be monitored. So if your patient is taking these xanthine derivatives and they don't go get their labs done, they have a risk of either being what? If it's too high, what is it called? If they have too much of a drug in their body.
Sounds like toxicity.
Toxicity, yes. Y'all like overthink. Like y'all know that stuff and y'all are like, I don't know, what is it called? If they have too much of it, they're toxic. And if they don't have enough, what is that called?
Intolerant.
Say it again.
Is it intolerant?
No, it's subtherapeutic. It's below, we have a therapeutic range. And if it's too low, then it's subtherapeutic. It's not doing anything. If it's too high, then they're toxic.
Like SUV.
Yes, like subway, sub. So those drugs, xanthine derivatives, they're used for the same thing. They cause bronchodilation, but they absolutely are given, they absolutely have to be monitored very closely. So why would a patient, I don't think I've ever taken care of a patient on a xanthine derivative. I don't think. But why would that be a good response for some people? I mean, not a good response, a good drug for some people. Does anybody know? Why would we, if we have all these other drugs, why might we use something that we know is a little more dangerous for them?
Because they have like a tolerance to that, and so it wouldn't.
Yes, they can be non-responsive to these drug classes. That's one reason. There's about 3 reasons. So if they're non-responsive to one of these others, because it has a different mechanism of action, right? It works differently. So if they're non-responsive to one of these other classes, then we would give them that. What's another reason? Y'all might not know these. It's okay if you don't. Just throw straws at me.
Would it be they're allergic? Maybe?
Say again. They're what?
Like they're allergic to an ingredient in one of the others.
Yes. They could be allergic to something in one of these. Perfect.
Then I'm going to interfere with other medicine.
Yes. And medication interference. Yes.
They have to check that all.
Yeah, they have to be checked on. You have to go more frequently.
Are they less expensive?
Yes, that's what I was looking for. They're a lot less expensive.
I just read it.
If all else is like
Miss Trailer. The computer's frozen.